All right, hey everyone, welcome back. We like to do these deep dives every now and then, and today we're going to be tackling surgical approaches for the humerus and the elbow.
Yeah, super important topic, and especially relevant if you're, gearing up for those postgraduate exit exams.
Exactly. I mean, those exams, they love to throw these tricky surgical approach questions at you.
Oh, absolutely.
So to make sure we're all on the same page, we're going to be using the Ortho Simple Notes. They're from this website, mokyingren.sg. Have you heard of it?
Yeah, it's a great resource.
It is. And, the notes are put together by Dr. Mok Ying Ren. He's a sports surgeon over at National University Hospital in Singapore.
I know him, actually.
Oh, do you?
Yeah, we were actually in the same FRCS cohort back in 2022.
Oh, wow. Small world.
He's a brilliant surgeon, very meticulous.
And his notes, they're like gold. Super clear, easy to understand. So yeah, big thanks to Dr. Mok for putting these together. Now let's get into it. First things first, when we talk about surgical approaches, it's not just about memorizing the steps.
Right.
It's about understanding the why.
Exactly. Like, why choose one approach over another?
Right. It's about thinking like a surgeon. You're in the OR, you've got this patient in front of you. What are the factors you're considering before you even make that first incision?
Yeah, the fracture pattern for sure. Patient
Yeah.
factors, any previous surgeries, potential complications, it all plays a role.
Exactly. Okay, so let's jump right in. Imagine you need to access the front of the humerus. What's your go-to approach?
Well, the anterior approach is definitely the workhorse for the humeral shaft, especially the brachialis splitting technique.
Okay, the anterior approach, brachialis splitting. Why is this one so popular? What makes it the workhorse, so to speak?
It comes down to the exposure you get. The brachialis splitting technique really opens up the humeral shaft nicely.
Okay, I see. So it's all about getting a good look at the bone, I guess.
Yes, exactly. But it's not just about blindly splitting the muscle. The key is understanding the plane of dissection. You're working between the lateral and medial parts of the brachialis muscle, guided by the radial nerve laterally and the musculocutaneous nerve medially.
Okay, so you're following those nerves to guide your dissection.
Absolutely. And you have to be super careful with the radial nerve. It goes through the intramuscular septum about 7 centimeters above the lateral epicondyle.
Ah, yes, the radial nerve. Always a concern in this area.
Yeah, you don't want to be messing with that one.
Okay, so let's say for some reason you don't want to split the brachialis. What are your other options?
Well, you could consider the anterolateral approach.
The anterolateral approach, okay. Tell me about that one.
So this one, it's a bit more muscle sparing. You're working between the lateral half of the brachialis and the brachioradialis.
Ah, so you're going around the brachialis instead of through it.
Exactly. And both of those muscles are innervated by the radial nerve. So again, nerve identification is crucial.
Makes sense. So it sounds like we have two main options for the front of the humerus. The anterior approach with brachialis splitting, or the anterolateral approach, which spares the muscle a bit more. Clinically speaking, what are the pros and cons of each?
Well, with the anterior approach, you get a more direct view, especially helpful for those complex fractures. But as we've said, there's that risk to the radial nerve.
Yeah, you don't want to injure that.
Right. Now, the anterolateral approach, it's a bit gentler on the muscles, which can be better for healing.
So less trauma overall.
Right. But you might not get quite as good of a view as you would with the anterior approach.
Okay, so it's a trade-off. More direct access versus less muscle disruption.
Yeah, exactly. And the best choice really depends on the specific patient and the fracture pattern.
It's a judgment call, really. Okay, so we talked about approaching the front of the humerus. Now let's flip it over. What about the back? How do you typically approach the posterior humerus?
For the posterior humerus, the triceps splitting approach is a common choice.
Triceps splitting. Got it. Walk me through that one.
Okay, so you make your incision right down the midline, and the plane of dissection is between the lateral and long heads of the triceps muscle.
Okay, and the radial nerve, is that a concern here too?
Oh, absolutely. Always got to keep the radial nerve in mind. It usually runs with the profunda brachii artery, so those two are your landmarks.
Right, so it seems like we've got a pattern emerging here. Whether you're going from the front or the back, that radial nerve is always lurking.
It is, but that's why knowing your anatomy is so important. You got to know where those nerves are so you can protect them.
All right, so we've covered the humeral shaft, both anterior and posterior approaches. Now let's focus on the distal humerus, that area just above the elbow joint.
Okay, yeah.
Now let's say you're dealing with a complex distal humerus fracture. What are your surgical options there?
Well, first things first. No matter which approach you choose for the distal humerus, there are some standard initial steps. Positioning is key. You want the patient either prone or in a lateral decubitus position with their arm on a radiolucent stand so you can get good intraoperative imaging.
Okay, so positioning is crucial. Got it.
And make sure they're on the edge of the table to give yourself room to work. You'll be using a sterile tourniquet, of course. And your incision, it's usually a midline incision, creating full thickness flaps to expose the area.
Okay, so midline incision, full thickness flaps. What else?
And here's the critical part. You need to identify and protect the ulnar nerve early on in your dissection.
The ulnar nerve.
Yep.
Right. Always going to be mindful of those nerves.
Absolutely.
Okay, so those are the basics for any distal humerus approach. Got it. Now let's get into the specific approaches. One option I've heard of is the olecranon osteotomy. What's the deal with that one?
So an olecranon osteotomy, as the name suggests, means you're cutting through the olecranon process of the ulna.
Wow. Cutting through the olecranon, that sounds pretty intense.
It can be, but it gives you this direct window to the distal humerus joint.
I see. So it's all about access.
Exactly. Now, it's not always the first choice, but for complex fractures, especially those involving the articular surface, it can be really helpful.
So when you do this osteotomy, where exactly do you make the cut?
You want to make your cut through the bare area of the sigmoid notch, about 2 to 3 centimeters from the tip of the olecranon. And if you're planning on using a screw for fixation, you'll want to pre-drill the area.
Okay, so pre-drilling for screw fixation. What about the shape of the osteotomy itself? Is it a straight cut, or is there a specific angle you aim for?
We usually do it in a chevron shape. Start with a saw, but then complete it with an osteotome.
Ah, the chevron shape. I've heard of that. And what are the options for fixing it afterwards?
You've got a few choices. Screws, tension band wiring, or even plating. Depends on the situation.
Okay, lots of options. Got it.
Yeah.
Now, let's say an olecranon osteotomy isn't the best option for whatever reason. What are some alternatives?
Well, the paratricipital approach is a good one. It's pretty much what it sounds like. You're working on either side of the triceps, creating surgical windows without actually detaching the muscle.
Ah, so you're sparing the olecranon altogether.
Exactly. This means less risk of non-union or hardware-related issues, and it preserves the triceps insertion, which is good for early range of motion.
Okay, that makes sense. Less disruption, faster healing. So are there any other ways to get to the distal humerus without cutting the olecranon?
Yeah, you could use a triceps splitting approach, similar to what we talked about for the humeral shaft. Or there's the Bryan-Mori approach, also known as the triceps reflecting approach. And then there's the TRP approach, stands for triceps reflecting and Lacanius pedicle.
Wow, so many options. Like orthopedic surgeons have a whole toolkit of approaches for just this one area.
It's true, and that's why understanding the nuances of each approach is so crucial. You know, Dr. Mok's Ortho Made Simple notes really go in depth on these. Super helpful resource, especially if you're studying for exams.
Yeah, it's amazing how much he's managed to pack into these notes, like a roadmap to navigate the complexities of orthopedic surgery. Well, on that note, I think we should take a quick break. When we come back, we'll dive into elbow approaches. This deep dive has been powered by the Ortho Made Simple notes from mokyingren.sg. And trust me, things are about to get even more interesting. Okay, so we've tackled the humerus. Now let's move on to the elbow. This joint is notoriously complex.
Oh, it is. So many structures packed into a small space.
All right, so let's start with the lateral side. What's a classic approach for this area?
Well, a very common approach is the Kocher approach.
Okay, the Kocher approach, named after Emil Theodor Kocher.
Right, that's right. A true pioneer in orthopedics.
So remind me, how does this approach work?
The key is the plane between the extensor carpial naris, the ECU, and the anconeus muscle.
Right, the ECU and the anconeus.
Yeah.
Got it. So you're going between those two muscles.
Exactly. And you have to remember your sequence of extensor muscles from lateral to medial. Anconeus, ECU, then EDC, and finally ECRB.
Anconeus, ECU, EDC, ECRB.
Got it.
So you're basically sneaking in between the anconeus and the ECU to get to the joint.
Precisely. Your incision runs from the lateral epicondyle to about 6 centimeters distal to the tip of the olecranon.
Okay, so it's not just about knowing the muscles, it's about knowing the landmarks too.
Absolutely. And speaking of landmarks, there are some important danger zones with the Kocher approach.
Oh yeah. What are we watching out for?
You've got the posterior interosseous nerve, the PY, and the lateral ulnar collateral ligament, the LUCL, both at risk with this approach.
Ah, the PAN and the LUCL. Got to be careful with those. Any tips for protecting them?
For the PIN, make sure you fully pronate the arm during the dissection. That helps to move it out of the way.
Okay, so pronating the arm is key.
Got it.
Got it. Now, are there any variations on the Kocher approach?
Yeah, you could do an EDC splitting approach. Instead of going between the ECU and anconeus, you split through the EDC muscle.
Interesting. So you're getting more exposure, but potentially weakening the EDC muscle,
Yeah, it's a trade-off.
like so many things in surgery, I guess.
Yeah, right.
Okay, we've covered the lateral side. Now, what about the medial side of the elbow? What are some common approaches for this area?
One that's commonly used is the Hotchkiss approach.
Hotchkiss approach.
Yeah.
Okay, what are the highlights of that one?
It's sometimes called the over-the-top approach. You're going directly over the FCU, the flexor carpi ulnaris.
So over the FCU. Interesting. And why is that beneficial?
It gives you a great view of the coronoid process of the ulna. It's more anterior than other medial approaches.
Ah, I see. So you're getting better access to the coronoid.
Exactly. Now, the plane of dissection here is between the FCU and the pronator teres muscle.
FCU and pronator teres.
Got it. And you'll need to elevate the anterior half of the pronator mass. That includes the pronator teres, the flexor carpi radialis, and the palmaris longus if it's present.
Okay. So elevating the pronator mass.
Okay.
Anything else?
And as always, ulnar nerve protection is super important here.
Right, the ulnar nerve. Always got to keep that in mind.
Absolutely. The incision runs longitudinally from the medial epicondyle along the medial forearm.
Okay, so it's a pretty straightforward incision. Now, how does the Hotchkiss compare to other medial approaches?
Well, there's the FCU splitting approach, where you actually go through the FCU muscle between the humeral and ulnar heads. Then there's the Taylor and Sham approach, which elevates the entire flexor mass off the ulna. And if you need maximum exposure, there's always the option of a medial epicondylectomy.
Wow, so many choices for the medial elbow. It's like there's an approach for every preference.
There really is.
We've explored the lateral and medial approaches. What about the anterior elbow? What options do we have there?
For the anterior elbow, the anterolateral approach is a common one. It's basically a continuation of the Henry's approach to the forearm.
Okay, the Henry's approach. We talked about that earlier, refresh my memory. How does this anterolateral approach work?
You'll want the patient supine with their arm on a hand table and a tourniquet in place. The incision, it's kind of a lazy S shape, starting laterally and proximally along the biceps muscle and curving medially along the brachioradialis.
Okay, a lazy S incision. Interesting.
Yeah, and proximally, you're working between the brachioradialis and the brachialis, but there's no true internervous plane here. Both muscles are innervated by the radial nerve. Distally, the plane is between the brachioradialis and the pronator teres.
Okay, so you're starting between the brachioradialis and brachialis, and then moving distally between the brachioradialis and pronator teres. Got it. What are the key steps in the dissection?
So first, you'll identify and protect the lateral antebrachial cutaneous nerve. Then you'll incise just medial to the brachioradialis and retract the brachialis, pronator teres, and biceps tendon medially. That'll expose the supinator muscle. You'll need to ligate the recurrent vessels from the radial artery in this area.
Okay, so protecting the lateral antebrachial cutaneous nerve, ligating those recurrent vessels. What else?
Then you'll incise the supinator muscle with the arm fully supinated to protect the PIN.
Ah, right. Supinating the arm to protect the PI.
Got it.
So many steps to keep track of. Now, how does this anterolateral approach differ from other anterior approaches?
Well, there's also the anterior approach to the cubital fossa, which is mainly used for exploring the brachial artery.
Okay, so the anterolateral approach is more for the elbow joint itself, and the anterior approach is for the cubital fossa.
Right. The anterior approach runs between the pronator teres and brachioradialis. Similar incision, kind of that lazy S shape, but the curve goes medially and proximally. The key landmark here is the bicipital aponeurosis, also known as the lacertus fibrosus. You incise that at its origin from the biceps tendon.
Okay, got it. So two different anterior approaches, each with its own purpose.
Exactly.
We've covered a lot of open approaches to the elbow. Before we move on to the forearm, I'm curious about elbow arthroscopy. It seems like arthroscopy is becoming more and more popular for a lot of orthopedic procedures. Is that something Dr. Mok covers in his notes?
He does. Elbow arthroscopy is a great tool, but you have to know the portals and nerve safety considerations.
Okay, so before we even get into the portals, what's important to consider before doing elbow arthroscopy?
Always confirm whether the patient has had a previous ulnar nerve transposition. It can change your landmarks.
Right. Previous surgeries are always important to know about.
Absolutely. Now, typically the patient is positioned supine with their arm held across their body, or sometimes in a lateral decubitus position, kind of like what we discussed for olecranon fixation.
Got it. Positioning is key. Now, what about those portals?
Well, there are a lot of portals described, but some are more common than others. The proximal anteromedial portal, or PMP, is one of the most important ones. It's usually the first one established.
Okay, the PMP portal. Where's that located?
It's about 2 centimeters proximal to the medial epicondyle. just anterior to the intermuscular septum.
So just above the medial epicondyle. Got it.
Yeah, and you'll dissect carefully above the septum and insert the trocar. You want to keep it in contact with the anterior humerus to avoid injuring the median nerve.
So aiming for the anterior humerus to protect the median nerve. Makes sense.
Mhm.
What other portals are commonly used?
Another one is the proximal anterolateral portal, or PAL-LP. It's about 2 centimeters proximal to the lateral epicondyle and about 1 centimeter anterior to it.
PALP portal. Got it. Any tips for placing that one?
You can use a spinal needle while visualizing through the PMP portal to help with placement. And again, you want to angle the needle towards the humerus as you go through the joint capsule. That way you avoid the radial nerve.
So similar concept as the PMP portal, aiming for the bone to protect the nerve.
Exactly. And then there's the direct posterior portal. This one is about 3 centimeters from the tip of the olecranon. You're going directly through the triceps muscle here to access the joint.
Direct posterior portal. Got it. It seems like there's a lot to know about elbow arthroscopy.
There is. It's a whole other world.
Yeah.
But these Ortho Made Simple notes are a great place to start.
They really are a fantastic resource. Dr. Mok has done an amazing job of breaking down these complex topics.
He really has. It's like he took all the essential information and put it in one place.
We've covered so much ground already, from humorous approaches to the intricacies of the elbow. And to think this is just a glimpse into the world of Ortho Made Simple.
I know it's incredible how much information is packed into these notes.
All right, well, we're going to shift gears now and move distally. When we come back, we'll explore approaches to the forearm and wrist. Don't forget, this deep dive has been brought to you by the Ortho Made Simple notes, available on mokyingren.sg. We're back and we're ready to talk forearm and wrist. What are some of the must-know approaches for this area?
Well, one that you'll use all the time is Henry's approach. It's really versatile. It gives you access to pretty much the whole forearm.
Henry's approach, okay. Remind me about that one.
The key with this approach is the plane of dissection. You're going between the brachioradialis muscle, which is part of the mobile wad, and the pronator teres and flexor carpi radialis muscles.
Okay, so between the brachioradialis and the pronator teres and FCR.
Exactly. Your incision runs all the way from the distal biceps tendon down to the radial styloid.
Wow, so it's a long incision along the radial side of the forearm.
It is, and you have to be really careful because this area is packed with important structures.
Oh, yeah. What are the main danger zones with this approach?
The big ones are the superficial branch of the radial nerve, the SRN, and the radial artery.
Ah, right. Those two run together along the lateral side of the forearm. How do you protect them during the dissection?
So you start by carefully dissecting through the subcutaneous tissue. Identify the brachioradialis and then go medially. Incise the fascia and dissect down. You'll need to ligate the recurrent branches to the mobile wad and make sure you retract the radial artery medially to keep it safe.
You know, I remember when I was a resident, I really struggled with the concept of the mobile wad.
Yeah, it can be confusing.
What finally made it click for you?
For me, it was understanding their function. These muscles, the brachioradialis, extensor, carpi radialis longus, and brevis, they all originate from the lateral epicondyle of the humerus, and they work together to flex the elbow, extend the wrist, and radially deviate the wrist.
Right, that makes sense. So back to Henry's approach. You said it can be used for the whole forearm. Does the dissection change depending on where you are?
It does. The deeper dissection really depends on which part of the forearm you're working on. So in the proximal third, you'll need to incise the supinator muscle from its medial edge. And it's easier to do that with the arm supinated.
Okay. Supinating the arm for the proximal third, what about the middle third?
For the middle third, you're going through the pronator teres. So pronating the arm helps for that part.
Okay. And distally?
Distally, you're working with the flexor pollicis longus, the FPL, and the pronator quadratus.
Got it. So depending on where you are in the forearm, you adjust your technique accordingly. Are there any variations on Henry's approach that we should know?
Yeah, there's the trans-FCR approach. It's basically a modification of Henry's that goes through the FCR sheath.
To the FCR sheath. Okay. And this is often used for discal radius procedures, right?
Exactly. So what's the main difference between this modified Henry's approach and the classic Henry's approach?
Well, the trans-FCR, you're going through the FCR sheath, so I guess the retraction of the radial artery would be different.
You got it. In the classic Henry's, you retract the radial artery medially. In the modified Henry's, you retract it laterally.
Makes sense. Okay, so we've covered Henry's approach and its variations. Are there any other approaches for the forearm and wrist that we should talk about?
The Thompson approach is another important one. It's an extension of the Kaplan approach to the lateral elbow. We often use it for distal radius procedures.
The Thompson approach. Okay, tell me more about that one.
The plane of dissection is between the ECRB and EDC muscles proximally, and between the ECRB and APL distally. Your incision goes from the lateral epicondyle to Lister's tubercle. The P is at risk with this approach. It pierces through the supinator muscle.
Right, the PAN. And how do you protect it?
Supinate the arm fully during the dissection.
Got it. Supination for PAN protection. Seems like that's a recurring theme.
It is. Knowing your anatomy is so crucial for these approaches. You have to be aware of the structures that are at risk and take steps to protect them.
Absolutely. Well, we've covered so much in this deep dive, from humerus and elbow approaches to the forearm and wrist. It's amazing how much information Dr. Mok has managed to condense into his Ortho Main Simple notes.
They really are a fantastic resource, especially for residents preparing for those tough exams.
I completely agree. Well, that wraps up our deep dive into the Ortho Made Simple notes from mokyingren.sg. A huge thank you to Dr. Mok Ying Ren for creating such a valuable resource for the orthopedic community. We hope this episode has been helpful for you, whether you're a resident preparing for exams or just brushing up on your knowledge. Remember, guys, mastering these surgical approaches takes time, practice, and a solid understanding of anatomy. Keep learning, keep practicing, and most importantly, never stop being curious.